Tantor Audio, a division of Recorded Books, presents Bipolar Disorder for Dummies, 4th edition, by Candida Fink, M.D., and Joe Cranak. Narrated by Anne Richardson. Publisher's note: in this audio edition you will hear references to figures present in the print and e-book formats of the book. Limit of liability, disclaimer of warranty. While the publisher and authors have used their best efforts in preparing this work, they make no representations or warranties with respect to the accuracy or completeness of the contents of this work, and specifically disclaim all warranties, including, without limitation, any implied warranties of merchantability or fitness for a particular purpose. No warranty may be created or extended by sales representatives, written sales materials, or promotional statements for this work. The fact that an organization, website, or product is referred to in this work as a citation and/or potential source of further information does not mean that the publisher and authors endorse the information or services the organization, website, or product may provide, or recommendations it may make. This work is sold with the understanding that the publisher is not engaged in rendering professional services. The advice and strategies contained herein may not be suitable for your situation. You should consult with a specialist where appropriate. Further, readers should be aware that websites listed in this work may have changed or disappeared between when this work was written and when it is read. Neither the publisher nor authors shall be liable for any loss of profit or any other commercial damages, including but not limited to special, incidental, consequential, or other damages. Introduction. Imagine yourself cruising down the highway at a comfortable speed of 65 miles per hour when your cruise control goes berserk. The speedometer climbs to 75 and then 85. You hit the button to cancel, tap the brakes. 90. Nothing slows you down. 95. Your car is shaking and weaving. 100. People are honking. 105. Police cars are chasing you. 110. Your spouse is yelling at you to slow down. 115. 120. Or imagine the opposite. You're driving through town in a 30-mile-per-hour speed limit zone. Nobody's in front of you. You're practically pushing the accelerator through the floor, but your car can only creep along at 3 miles per hour. Your neighbors are honking, passing you on the right, on bicycles, and giving you dirty looks and other gestures of discontent. When you have bipolar disorder, your brain's accelerator is stuck. At full speed, it launches you into a manic episode. In low gear, it grinds you down into a deep depression. If this were a situation with your heart, somebody would call an ambulance. Doctors and nurses would flock to your bedside. Loved ones would fly in from other states, and you'd get flowers and fruit baskets. But when your brain is stuck in park or overdrive, people tend to think you're lazy, you've snapped, or you're too weak to deal with life. Instead of flowers and fruit baskets, you get a pink slip and divorce papers. The good news is that the mind mechanics, psychiatrists, psychologists, and therapists have toolboxes packed with medications and therapies that can regulate your brain's accelerator. In this book, we reveal those tools, along with self-help measures you can take to achieve and maintain mood stability, and to help yourself feel a whole lot better. About this book. Although psychiatrists, psychologists, and therapists are better equipped than ever to treat bipolar disorder, studies increasingly show that the more involved patients and their loved ones are in the treatment plan, the better the outcome. Our goal in writing this book is to make you a well-informed patient or support person and to empower you to become a key player on the treatment team. Organized in an easy-to-access format and presented in plain English, the newest edition of Bipolar Disorder for Dummies brings you up to speed on bipolar disorder, explaining what it is, what causes it, and how it's diagnosed and treated. We present the most effective treatments, explain why preventive treatment plays such a critical role in keeping symptoms at bay, and point out the positive prognosis that you can expect with the right combination of medication, therapy, lifestyle adjustments, and support. In addition to comprehensive coverage of bipolar disorder, this book contains numerous first-person accounts from people living with bipolar disorder and their loved ones. These stories give you a glimpse inside the minds of people living with bipolar disorder, along with additional insight into how people deal with the challenges in their own lives. Foolish assumptions. When you or a loved one is diagnosed with bipolar, you automatically become a rank beginner. You never needed information about this illness before and probably had little interest in the topic. Now you have to get up to speed in a hurry. With that in mind, we assume that you know very little about bipolar disorder. If you've been to a doctor or therapist and received a diagnosis, however, you know at least a little. And if you've already researched the topic, you may know more than most people. But we assume that however much you do know about the topic, you want to know more, and you're committed to getting information from a reliable source. We also assume that you or someone you know has bipolar, or that you're at least somewhat curious about the condition. The more the disorder affects you, your family, or someone else you know, the more this book can help. Finally, we assume that you have a sense of humor. Yes, bipolar disorder can be brutal, but laughter is one tool that enables you to rise above the absurdity and frustration of dealing with it. Icons used in this book. Throughout this book, the following icons are verbalized to cue you in to different types of information you may or may not care to hear. Remember. If you happen to forget the rest of the stuff in this book, at least remember what we mark with these icons. Tip. Tips provide insider insight from behind the scenes. When you're looking for a better, faster way to do something, check out information flagged with this icon. Warning. Danger, Will Robinson, danger! This icon appears when you need to be extra vigilant or seek professional help. Bipolar Bio. Throughout the book, we feature cameos of people living with bipolar disorder. We use this icon to flag the stories they shared. Beyond the book. This book's cheat sheet offers assistance in identifying bipolar disorder, a list of bipolar medications, a guide for maintaining mood stability, and some advice on helping a loved one with bipolar disorder. You can get it simply by going to dummies.com and searching for Bipolar Disorder for Dummies cheat sheet. We also offer some bonus goodies at finkshrink.com/bonus. There you can find a mood tracking chart, a bipolar disorder glossary, and additional articles related to bipolar disorder, including 10 questions to ask a psychiatrist or therapist, and Helping a Loved One with Bipolar Disorder, Key Principles. Where to go from here. Think of this book as an all-you-can-eat buffet. You can grab a plate, start at the beginning, and feast on one chapter after another. Or you can dip into any chapter and pile your plate high with the information it contains. If you want a quick overview of bipolar disorder, check out the chapters in Part 1. Before you visit a psychiatrist for a diagnosis, see Chapters 4 and 5 to find out what to expect during the diagnostic process, and be sure that you're leaving the office with a comprehensive treatment plan. For information and insight into the medications used to treat bipolar disorder, head to Chapter 7. Turn to the chapters in Part 4 for self-help strategies. If you have a friend or family member with bipolar, skip to Part 6. Use the index to look up any bipolar term you're unfamiliar with and find out where we cover it in the book. Wherever you choose to go, you'll find plenty of useful information. 1. Getting started on your bipolar journey. In this part, understand what a bipolar disorder is and what it isn't, according to the diagnostic categories spelled out in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision DSM-5-TR, the book psychiatrists look to when developing their diagnosis. Explore genetic and non-genetic factors, such as physical and emotional stress, that likely team up to trigger the manic and depressive episodes characteristic of bipolar disorder. Take a look inside the different parts of the brain to understand the biology of bipolar disorder. Get a bird's-eye view of the diagnosis and treatment of bipolar disorder so you know what's involved and the sort of outcome you can expect when treatment proceeds according to plan. Chapter 1. Grasping Bipolar Disorder, Symptoms and Diagnosis. In this chapter, meeting the manual used to diagnose bipolar disorder, recognizing the two poles of bipolar, mania and depression, telling the difference between bipolar 1, bipolar 2, and other types, augmenting the diagnosis with specifiers and distinguishing it from other conditions, diagnosing bipolar in children, or not. When you initially encounter bipolar disorder, one of the first questions you're likely to ask is, what is it? The short answer is this. Bipolar disorder is a medical illness characterized by alternating periods of persistent, abnormally elevated, and depressed mood. The second question that most people ask is, can I get tested for it? And the short answer is no. Doctors arrive at a diagnosis by conducting a physical and mental status examination, taking a close look at a person's symptoms, medical history, and family history, and ruling out other possible causes. For guidance, doctors use a book called the Diagnostic and Statistical Manual of Mental Disorders, DSM, which presents the diagnostic criteria for determining whether a person is likely to have bipolar disorder. This chapter digs deep into the DSM to reveal what bipolar disorder is and isn't. It describes what elevated and depressed moods look like and provides you with the details you need to tell the difference between the various bipolar diagnoses, including bipolar 1, bipolar 2, and a related cycling mood disorder called cyclothymia. We discuss diagnostic specifiers that enable doctors to more precisely describe a person's symptoms and inform their treatment decisions. We distinguish bipolar disorder from conditions that may have similar symptoms and discuss other conditions that commonly accompany bipolar disorder, such as alcohol and substance use disorder. We wrap up with a discussion of the challenges of diagnosing bipolar in children and young adults. Cracking Open the Diagnostic Manual, DSM-5-TR. When a doctor in the United States diagnoses a mental illness, such as bipolar disorder, they turn to the American Psychiatric Association's, APA, Diagnostic and Statistical Manual of Mental Disorders, DSM, for guidance. This manual defines numerous patterns of symptoms and illnesses that are supported by scientific research and a consensus among a wide variety of experts. During the writing of this book, the APA recommends using DSM-5-TR, the 5th edition text revision, which was published in March 2022. Don't be surprised if you see references to earlier editions, such as DSM-4, the 4th edition. Throughout this chapter, we describe symptoms of bipolar disorder according to the diagnostic criteria presented in DSM-5-TR. Although the fundamental criteria haven't changed much over the past decade, some of the language has been modified, and criteria have been added in the most recent edition to help doctors arrive at and describe a person's condition more precisely. Remember, diagnosis isn't a simple matter of matching a list of symptoms to a label. Doctors are expected to use the DSM along with their training, clinical experience, and professional judgment to arrive at the correct diagnosis. The International Classification of Diseases, ICD. Doctors in countries throughout the world rely on the World Health Organization's, WHO, International Classification of Diseases, a classification system for all health issues. Chapter 5 of the ICD specifically addresses mental and behavioral disorders. The first edition of DSM, DSM-1, in 1952, grew out of ICD-6, which was the first ICD to include a section on mental disorders. Since 1980, Medicare and Medicaid, and therefore all other insurers, have required an ICD-9 code to be submitted for payment to be made. The DSM-3 was released at the same time, and it designated ICD-9 codes for all psychiatric diagnoses. When DSM-5 was released in 2013, the authors added ICD-10 codes in anticipation of the 2015 transition of all medical billing systems to ICD-10. Although the two systems have always had their differences, the current systems are closely aligned. The APA and WHO work together closely to coordinate their efforts. So, in clinical practice, a doctor using one manual should arrive at a similar diagnosis as a doctor using the other. Exploring the poles of bipolar disorder, mania, and depression. Bipolar diagnoses rely heavily on the type of mood episodes a person is experiencing or has experienced in the past. So to understand the different diagnoses, you need to know what constitutes a mood episode, specifically a manic, hypomanic, and major depressive episode. In the following sections, we present the DSM-5-TR diagnostic criteria for each type of mood episode. Manic episode. A manic episode is a period of abnormally elevated energy and mood that interferes with a person's ability to function as typical for that individual. Merely having some manic symptoms isn't the same as experiencing a manic episode. The symptoms must meet the following 4 criteria. Distinct period. The episode must last for at least 1 week or require hospitalization, and it must be characterized by atypically and persistently elevated, expansive, or irritable mood, and atypically and persistently increased goal-directed activity or energy that's present most of the day, nearly every day. 3 or more manic symptoms. 3 of the following symptoms must also be present during the week of mania. 4 if the mood is irritable rather than elevated or expansive. The symptoms must be present to a significant degree and represent a change from the person's usual behavior. Markedly inflated self-esteem or grandiosity, decreased need for sleep, for example, feeling well rested after 3 hours or less of sleep, excessive talking or the need to talk continuously, pressured speech, flight of ideas, when thoughts flow rapidly and topics shift rapidly and indiscriminately, and or the feeling that one's thoughts are racing, distractibility, attention too easily drawn to unimportant or irrelevant external stimuli as reported or observed, significant increase in goal-directed activity, socially, at work or school, or sexually, or psychomotor agitation, purposeless, non-goal-directed activity, excessive involvement in activities that have a high potential for painful consequences, including sexual indiscretions, unrestrained shopping sprees, and/or overly optimistic investments. Functional impairment. The mood episode must be severe enough to impair the person's ability to socialize or work, or require hospitalization to prevent the person from harming themselves or others, or cause the psychotic features, paranoia, hallucinations, or delusions, indicating that the person is out of touch with reality. See the section Presence or Absence of Psychosis later in this chapter. Not caused by something else. For a manic episode to count toward bipolar diagnosis, the mania must satisfy the following conditions. The mania can't be exclusively drug-induced or attributed to medical treatments. For example, if you're taking an antidepressant, steroid, or cocaine at the time you experience manic symptoms, then the episode doesn't count toward a diagnosis of bipolar disorder, unless symptoms persist after the effects of the substance have worn off. The mania isn't attributable to another medical condition. Mania caused by a medical condition is identified as a separate form of bipolar disorder, as described in the later section, Distinguishing Types of Bipolar Disorder. Hypomanic episode. A hypomanic episode requires the same number and types of symptoms as a manic episode that we discuss in the preceding section. For instance, the symptoms must represent a distinct change from a person's usual behavior patterns, and the changes must be observable by others. However, a hypomanic episode differs from a manic episode in the following ways. May be shorter in duration, just 4 consecutive days is enough to qualify as a hypomanic episode, doesn't cause severe functional impairment, doesn't require hospitalization, doesn't include psychosis. Remember, hypomania doesn't typically result in serious relationship problems or extremely risky behavior, but it may make others feel uncomfortable. On the other hand, hypomania can make you more engaging, so you may become the center of attention, which may feel good to some people or awful to others. For some people, hypomania creates periods of high creativity and/or productivity that are positive experiences. Major depressive episode. During a major depressive episode, you may feel like you're swimming in a sea of molasses. Everything is slow, dark, and heavy. To qualify as a major depressive episode, 5 or more of the following symptoms must be present for at least 2 weeks straight. These symptoms must be changes from usual behavior, and the episode must include at least 1 symptom of depressed mood or loss of interest or pleasure. Depressed mood most of the day, nearly every day. Markedly diminished interest nearly every day in activities previously considered pleasurable, which may include sex. Notable increase or decrease in appetite nearly every day, or a marked change in weight, 5% or more, up or down in a span of 1 month or less that isn't due to planned dietary changes. Sleeping too much or too little nearly every day. Psychomotor agitation or slowing, moving and thinking uncharacteristically slowly, or experiencing mental and physical agitation nearly every day, which is observable by others and not just internal sensations. Daily fatigue, feelings of worthlessness, excessive guilt, or inappropriate guilt nearly every day. Uncharacteristic indecisiveness or diminished ability to think clearly or concentrate on a given task nearly every day, experienced internally and or observed by others. Recurrent thoughts of death or suicide, suicide ideation, a suicide attempt, or a plan to commit suicide. These symptoms must cause significant problems in your day-to-day life and function to qualify as indicators of a major depressive episode. If they occur solely in response to use of a medication or substance or another medical condition, then the episode has its own category, such as substance medication-induced depressive disorder or depressive disorder due to another medical condition, and therefore doesn't count toward a diagnosis of either unipolar or bipolar depression. Remember, of course, people who experience a significant loss or crisis in their lives may have many of these same symptoms. Doctors must rely on their clinical experience, observations, and what their patient tells them to determine whether the person is experiencing a major depressive episode or intense sadness that's a normal part of the grieving process. In addition, cultural factors may play a role in how deeply a person feels and expresses emotion in response to a loss. Not your average moodiness. Most people experience mood fluctuations to some acceptable degree, but bipolar mood episodes are amplified and extend far beyond the usual levels of discomfort, to the point of impairing a person's ability to function and enjoy life. Episodes associated with bipolar disorder make a person think, feel, speak, and behave in ways that are extremely uncharacteristic of the individual, and they may drag on for weeks or even months. They strain relationships, disrupt lives, and often land people in the hospital or in legal trouble. And they're not something a person can just snap out of. Figure 1-1, shown in the print and ebook formats of this book, demonstrates the difference between normal mood fluctuations and those related to bipolar disorder. Not attributable to other psychotic disorders. To make a diagnosis of bipolar 1, bipolar 2, or cyclothymia, the doctor must determine that at least one manic episode is not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or other specified or unspecified schizophrenia spectrum or other psychotic disorder. Schizoaffective disorder is a separate diagnosis from bipolar disorder. With schizoaffective disorder, psychotic symptoms persist after the mood episode resolves. The point is to clarify that a bipolar diagnosis can't be made if symptoms include disordered thinking and reality testing that aren't part of a mood episode. For more about psychosis, see presence or absence of psychosis later in this chapter. The other psychotic disorders listed in that section do not include mood symptoms in their diagnostic criteria. If someone with one of these conditions experiences a manic episode on top of their pre-existing diagnosis, it would not be coded as bipolar disorder. Distinguishing types of bipolar disorder. Bipolar disorder wears many masks. It can be happy, sad, fearful, confident, sexy, or furious. It can seduce strangers, intimidate bank tellers, throw extravagant parties, and steal your joy. However, based on research, psychiatrists have managed to bring order to the disorder by grouping the many manifestations of bipolar into categories that include bipolar 1, bipolar 2, and cyclothymic disorder.
Sample complete. Ready to continue?